Hello, everybody. Welcome, and I'd like to welcome everybody to our seventh AVE. For those of you that are keeping count, um, we have a great program set for you tonight. But before we get started, I'd like to start with a prayer in order to get us going. So, in the name of the Father, the Son, and the Holy Spirit, Amen. I'd like to pray for everybody affected by COVID, for the community, for Belen, for Rick Raimundez, which was a big part of this when this all started, and for all those alumni that have passed during COVID. Special prayer for Anthony Perotti as well. We're behind him and his family, and thank you, and thank God for what we have, and for our blessings. So thank you. In the name of Jesus Christ, Amen. So, like I said, I'd like to welcome you to our medical professions AVE. Last one we had with these guys was back in April. So it's amazing that 4 months have passed since then, and so much has happened. And thought it was a good idea to revisit with these guys. We have some familiar faces, but we also added a couple of new faces, and very, very nice to have that. So I'll be introducing them and letting you know what our program is going to be about. So first, Dr. Eduardo Martinez DeBouchet, class of 1990. He's with critical care at Baptist Hospital. He was in our first AVE. Dr. Bert Moreno, class of 96, cardiologist. He's now the chairman of BASH, which is sponsoring this event. He will be moderating as well. Dr. Juan Perez, infectious diseases. He was with our last AVE as well. He's a parent of two alumni. Jose Romano, AVP Professional Services, Doctors Hospital. Happy to have him, class of 88. And Dr. Gabriel Suarez, class of 04, our youngest guy, primary care physician with Baptist, also Baptist West. So we have a great group of guys here, great representation. Couple of housekeeping things. We do have you on mute. Please use the chat to ask questions. We're going to try to address everything we can, and then we'll be answering questions as well. So with that said, I'd like to turn it over to Dr. Bert Moreno and get started. Thank you.
Thank you, Carlos. Thank you for hosting this. Thank you to Belen for putting this together. And hopefully we can provide some good information for our community. First question that I just wanted to ask to the group in general is, since April, we had our last Zoom conference, and a lot has changed, but a lot is still the same. And I just wanted to get the perspective from the physicians and the administrators who are working on this day to day as to how they feel in general about how we progressed in terms of our overview of how we're looking at COVID and how we're managing it with our patients. So I'll just leave it open to the field at that.
I guess I can go first. I mean, really, for my patients, a lot hasn't changed in the fact that they come to me and they say, Dr. Suarez, you know, what should I do? What are the most important things that I should be concerned about? What are the most important CDC recommendations? And honestly, what I tell them is the CDC recommendations that's most important is the one that they've been having for years. And that's doing daily exercise, taking care of yourself and your loved ones. So managing your chronic conditions, managing your diabetes, making sure you're eating right, making sure you're getting enough sleep. Obviously, there's a lot of other information that's important. There's a lot of other things about COVID regarding social distancing and wearing masks, all of which we can, expand upon. But I think individually, we still have to go back to the fact that our health and our wellness is one of the most important things and one of the things that we can control the most. And so that's really what I'm preaching to my patients, to myself, and obviously to my family.
Yeah, Dr. Suarez, so you're a primary care physician. You're oftentimes the first line of defense against COVID, and the first line where patients are accessing healthcare. How's it going in terms of testing in your office, or how's it going in terms of the recommendations you're making to patients as they try to navigate the start of the process of dealing with the virus?
Yeah, so I mean, definitely one of the most beautiful things is that we've been able to keep everyone safe. Safety is our main priority, and access to care is huge. And we've been able to do that through telemedicine. You know, we've been in our office on the virtual front line, and we have basically 24/7 service where anyone, anywhere. At first it was expanded to the whole nation. Actually, we were taking care of, and then it shrunk down to Florida and now into the Tri-County area. But we're offering those services, and we're triaging patients and giving them recommendations, and also educating them and able to manage not only COVID questions, but if they have other questions about their chronic conditions. And we're keeping them home, which is the most important thing, trying to keep them out of the urgent care and the ER, as not because it's a dangerous place to be, but more to not overrun the hospital, and also not to unnecessarily expose themselves if they don't have to. A lot of these cases, thankfully, can be managed at home. And so with a little bit of reassurance, a little bit of education, a little bit of medical management, you know, I think that we've done a really tremendous impact on keeping people home and keeping people safe. You know, there's a lot of difficulties with testing. We have numerous community testing sites. Obviously, we've seen a lot of delays in test results getting back, an overabundance of testing requirements from employers and different organizations and that the patients are involved with. So it has been very difficult. It has been a significant demand, but I think things are getting better in that regard.
Anybody else want to chime in on access to COVID testing and the current guidelines for testing?
I think the current guidelines is something we should go over. So most recent CDC guidelines have changed, and we do realize that if you test positive for this disease, that you can continue to test positive for this disease up to 12 weeks. It's possible to be positive. That doesn't mean you're contagious. So the CDC reflects that in their new guidelines. And if you have had the disease for over 12 days from initial symptom onset and you've been asymptomatic for 3 days, for the last 3 days, at that point, they state that you are not likely to be contagious. We're using the same guidelines with our patients in the hospital in terms of moving them out of isolation at that point. So if we're willing to, you know, to take the risk of stating that they're not contagious, I think we can share that same recommendation with patients on an outpatient basis. Dr. Perez could probably chime in a little bit later, because it's not necessarily the same for all patients. If you do have some immune, you know, compromised conditions, or you're on medication that can potentially suppress your immune system, that 12-day scenario might not be you. You might be able to be a little bit contagious for a little bit longer. It's a little bit different group, but for generally most of the population, we know we can safely get you back to work once you've had the disease again, you know, over 12 days and been asymptomatic for a minimum of 3 days, you know, no fever, no symptoms. And that's what, you know, that's what we're doing. And I think that doesn't mean that you won't be positive. And I don't want you guys to go out there and continue to seek tests to wait till you're negative, because your test may be positive, and that's okay. That doesn't mean you're contagious. We haven't been able to generate a live viral culture, right, from those inoculum, from those particulate. So what that basically is, again, it's just we're basically amplifying all those reverse transcriptase processes of a virus, you know, and that we can really amplify it to show that that the viral particles or pieces of them are still there, but that doesn't mean you're infectious. So a lot of my patients, friends, families have asked, do I test again? I go, don't even go through that. It's going to take forever to get your test back. It's a waste of time. If you've been asymptomatic now and you're 12 days out from your disease, you're asymptomatic 3 days, you're generally safe to go back to work. But I'll throw that to Dr. Perez Morales, because that is his camp over there. So I just want him to touch base on it.
CDC guidelines have changed. I agree with that. And we have a lot of new tests available now, including antigen testing, which have come and seem to be ready for prime time. Particularly the two companies, Sophia platform from Quidel and Becton Dickinson, Veritor. And we're all familiar with antigen testing from influenza, from the experience with influenza before. They're usually reliable tests. They work best during the first 5 days when the viral load is high, but they're also associated with a significant number of false negative results. And most of them, even though they've changed their package insert information, their sensitivity is about 85%. But the problem with the testing, the way I see it, is not necessarily the fact that it's not necessarily available when we need it most, but nursing homes in particular are not following those guidelines that you were referring to. Most nursing homes are still requiring 2 PCR tests 24 hours apart in order to discharge the patient back to the nursing facility, which creates a lot of backlog and traffic in the hospital because we're not able to move those patients. Going back to testing, other than the new, even in-home testing available now, saliva, first morning saliva, nasal swabs, PCR technology, nasal swabs that are being done from home, all those testings are actually pretty decent and have been favorably compared to NP PCRs in different studies that have done comparisons head to head. I just wish, that we were all on the same page when it comes to applying guidelines and recommendations. Because as you were saying, it is absolutely true that we haven't had any positive viral cultures after day number 8. And yes, immunosuppressed patients can absolutely shed longer and probably should be isolated for a little longer period of time. And there's not a lot of information in that patient population as far as viral cultures or dynamics. But other than that, the regular patients that we're talking about, we're not all playing the same game. It's a different ball game everywhere we practice.
Yeah, you're absolutely right. We have had a lot of issues in our hospitals with discharging patients, and we have found some skilled nursing facilities to take patients that are still positive or to manage that. But during peak, when our hospitals are full, when different partnered skilled nursing facilities have, you're right, different rules for taking the patients, it becomes very difficult to discharge patients that are appropriate for discharge to make space for patients that need acute hospital care. So that has been difficult, and you're right. There's been, despite CDC guidelines, there's been a little bit of resistance from some of our partnered skilled nursing facilities to accept patients. And that's an issue with backlog.
Sorry to interrupt, but there's also some resistance from employers. I've written countless return to work letters. I lost count now. And stating where the patient, following CDC guidelines, the non-test based strategy, patient's been asymptomatic for more than 3 days, 10 days after their test result or the start of symptoms, and they won't take that patient back unless they get testing performed, even with a physician's note. And that's a significant burden on the individual and the family that they have to take care of.
It's also a burden on our testing. I mean, so we were doing great with testing until we hit another surge. And then when we hit a surge, all of us noticed, even in-hospital tests started backing up a little bit because all of a sudden there's just that much more testing going on. You guys out there are familiar with the number that everyone looks at, which is the positivity of tests being done. But the reality is, as the tests are, the higher percent positive tests are coming through, that also means there's probably a lot more people seeking tests that are being turned away on a daily basis or having trouble getting their test results. So absolutely, if we're asking people to get unnecessary testing, we're burdening a system that's already stressed.
No, we're asking doctors and nurses to come back as per the guidelines we're discussing to our hospital systems. Physicians and hospital providers who have had a positive test are coming back according to these guidelines. Surely non-practicing physicians and other jobs should certainly be able to get back to work. Jose Romano is an administrator in the Baptist Health System, specifically at Doctors Hospital, and I was wondering if he'd chime in. Resources of all kinds have been stressed within our hospital systems, and I was wondering if you could help us out with understanding how this affects our healthcare locally.
Sure. So thank you very much, and I appreciate the question. And you started off asking the question, how have things changed from April till now? And I think one of the biggest things is when this first hit, we really didn't know, and the clinical providers weren't sure how it was going to affect the patient's stay in the hospital. And at the very beginning, we canceled all elective surgeries, including in our ASC, which is right next to our hospital, and in our hospital, to make room for some of these patients. So we also saw a significant decrease in the amount of people seeking care for non-COVID related illnesses in our EDs. So prolonging, chronic disease care and taking care of some of those things in our EDs. What has changed at this point, I think the clinicians have done a great job since April understanding this disease and learning how to treat it. And we're beginning to see an increase in people coming back for non-COVID related issues. But to speak directly to what you asked, we're very fortunate at Baptist Health and the system that we have. We have 11 hospitals all the way from Palm Beach County down to Monroe. And we use these dashboards to measure capacity and to kind of maneuver. As you can imagine, one of our hotspots right now is in South Dade. Homestead Hospital has been experiencing some capacity issues. But what we're able to do is move some of those patients into other hospitals, into other ICUs, based on this software system that we have, that we understand where the capacity is available. We've done since our peak, and I think we can all agree here, and the clinicians can chime in, but July 13th was the peak of hospitalizations in our system. And it's steadily decreased since then. I think we've seen lower length of stays, lower acuity, and I think we're in a spot now. I mean, at one point, I was talking about this with Dr. Martinez DeBouchet, we converted some of our offices into patient care rooms. We did some engineering workarounds to make ambulatory surgical rooms into negative pressure rooms to be able to have isolated patients. So really, my hat goes off to not only the clinicians that have dedicated so much time to this disease, but also the people behind the scenes, the people in engineering, the people in EVS, environmental services that have really helped us manage this initial surge that we went through in July. And now we're at a place where I think, we're in a good spot now.
Yeah, in some ways there was a huge panic in April for hospital systems. But something that's interesting that's happening over the course of the last couple of months is that the actual capacity of hospitals in April never passed 60% in the ICUs either. Current capacity in the hospitals is about 20% for regular beds and 17% or so this is countywide, not in individual hospital systems. What are some of the things that your hospital systems have done to try to decrease that capacity in that hospital and open up the beds for the people who need it most?
We had to come up with significant innovative solutions in order to maximize the capacity of our hospital. So as Jose referred to, we have our transfer center. I'm the medical director of our transfer center for Baptist Health, and we move the patients to facilities that are less affected, having basically spanning 4 counties, as Jose said, since we're going all the way from West Palm Beach to Monroe. You notice that this disease was very focally affected, and we were able to stretch our resources amongst all those facilities. Anything from ventilators to staffing, anything that can be moved, and then at some point patients, as Jose mentioned, we're moving patients through. So that was the first step. The other thing that we did, we innovated with a company called Massimo that makes this home pulse oximeter device that measures your oxygen with your pulse and your respiratory rate on a continuous basis, and it hooks up to your iPhone through an app, and then the app talks to us on a dashboard over here in our transfer center. And we started monitoring patients that were discharged from the emergency department that would have normally been admitted for monitoring because we would have been worried about them. And then we expanded that a little bit further, and some of them were sent home with a little bit of oxygen if they needed it. And then we started moving a little bit forward and saying the patients that were getting better but still needed a little bit of oxygen, we started sending those patients home a little earlier than we would have, and that opened up some beds. And they were happy. I mean, instead of being stuck in a hospital without your family for monitoring, they're at home, they're being monitored, and they're being looked at 24/7, just as if they would have been in the hospital with a continuous device, and our nurses calling them and reaching out to them and guiding them with their care. We've managed over 300 patients that way, and that's 300 hospital, beds times the amount of days that they would have been there. Could have been up to 6 days. If you look at it, it's potentially 1,800 hospital days, that were avoided in order to keep those beds available for patients that were a little bit sicker. And it's not to say some of them did need to come in. Sure, we called them and said, you know what, you're doing a little worse, let's bring you back, or you're a candidate for some of these drugs that we can talk about in a little bit. And we brought them back into the hospital. But they were happier. They all loved the device. Most of them wanted to keep it on. Even the ones that were rehospitalized with it said, can I keep this thing on, man? This thing is saving my life. You know, there are people monitoring me here at all times. So it was a new innovation. We were stretched. I mean, there's no doubt. And you mentioned that there was hospital capacity. Well, you know, we made that capacity. So there wasn't real hospital. The pre-existing capacity beds were stretched to make those extra % beds. So most of us have opened up, as Jose mentioned, you know, beds in areas that you wouldn't have imagined thanks to engineering. And in one of our hospitals, in one day alone, you know, we used the same amount of oxygen that we had used in a whole month the year before, you know, which was unbelievable. Year to year, they were actually using 30 times the amount of daily oxygen that, you know, that was being used. That's what the demand was. This has been impressive, but we're actually preparing right now as a system how to do it in case we surge again in the fall and the winter. How could we do this if we're at 200% of what we just received? So we're getting over this surge, but by no means do we believe that this is not possible to happen again, and maybe even a lot worse. So we're preparing, because I mean, we're going to be responsible for it.
We're prepared. I think the hospital systems are prepared. The docs have kind of adjusted to this new normal of COVID being a diagnosis that's omnipresent in their daily lives. Dr. Perez Morales, you know, in April, most of our discussions surrounded about the possibilities of treatments, but we really didn't have too many definitive treatments that have been studied and validated. How are we doing in terms of treatment of COVID, and what are the tools that the docs have in their armamentarium against the disease?
Well, it's sad what I'm about to say, and perhaps reflects my personal opinion, but I think we're probably about the same, maybe a little worse off than we were in April. And this may reflect the higher number of patients, the fatality rate that we've seen with this second wave, if you want to call it that way, and the overwhelming amount of patients that have flooded our hospital systems. Because in all honesty, I think everybody has to agree it's been overwhelming. Going back to the question, in April, we hardly had any remdesivir available. Most of Florida didn't have remdesivir, which is an antiviral, and it's the drug that's supposedly most promising in the clinical trials. In my opinion, remdesivir at this point is probably overrated. The trials seem to indicate that, you know, the length of stay was shortened by 4 days, which was the, you know, get excited about factor with remdesivir. The key to administering the antiviral drug is to give it early. The earliest, the better. If you wait until the patient is, you know, into the second week of his illness or about to get intubated, it's probably fruitless to administer and a waste of time and effort. We have dexamethasone, which we always had, but at the beginning there was a lot of controversies about being, you know, contraindicated, prolonging the viral shedding, replication, immunosuppression, etc. Then we had the recovery trial from UK that was actually the first study that showed improvement in mortality, 28-day mortality. Particularly those that are oxygen dependent or intubated. The ones that don't require oxygen did not show any significant improvement. As a matter of fact, it may have been a little detrimental. But that's as far as steroids go. In my experience, I find very few cases of the patients that I've treated, and I probably treated between March, April, and now June and July, which were brutal, probably close to 200 patients, if not more. I've had censuses of 60, 70 patients by myself, which is overwhelming. And then we have tocilizumab, which according to the most recent trial by Genentech, it's another drug that perhaps shortens a little the length of stay in the hospital, but most recently was found not to affect mortality at all or need for intubation. So tocilizumab is a very expensive proposition based on what we know now, even though there's still a lot of anecdotal reports indicating that in conjunction with corticosteroids may be effective, save lives, and improve prognosis overall. And then finally, convalescent plasma. And again, we're back to square one. Convalescent plasma one time seemed to be the holy grail antibodies from patients that have recovered from COVID. You give them an infusion of antibodies. Hello, they get better, they improve faster. The most recent randomized trial of 103 patients that was recently published didn't show any improvement whatsoever. And some of the physicians that I know in infectious disease are not really sold on the convalescent plasma. So bottom line is some of the drugs we have, if they're going to work, they need to be given early. They need to be given judiciously. And it depends significantly, I think, at the time of presentation into their illness when the patient comes to the hospital. Some patients come a little too late. They have been symptomatic for, 10, 12, 14 days. They have been on the azithromycin, hydroxychloroquine, ivermectin kits that people are selling, which, probably should go to jail, $75, $100 selling kits to patients, which is criminal, in my opinion. Or they have been going from doctor to doctor getting antibiotics, which are not indicated in the management of this disease, which is something I would probably like to talk about a little bit more later on during this webinar. The antibiotic abuse has been tremendous over the COVID-19 pandemic, and there's no need whatsoever to give antibiotics, even empirically. The studies show that the risk of superinfection, both bacterial and fungal, is either 7 to 10% in that range. So the use of antibiotics, I certainly don't use them, and I discourage people from using antibiotics. There's combinations going around of cefepime, doxycycline, et cetera, worthless in my opinion.
You said something really interesting there, Eddie, and maybe you can comment on this, Dr. Perez Morales, about getting into the hospital or getting to see a provider very early on in the process if you suspect or if you feel symptoms. I know in cardiovascular disease, the incidence of heart attacks have gone down markedly in hospitals. And it's not because people are having less heart attacks, or at least the suspicion is people just aren't searching for appropriate care when they present with symptoms that are consistent with heart attacks. In terms of COVID, getting in early is important. Why? Isn't it related, Eddie, to the inflammatory process that's caused by COVID and what we can do about it before that cytokine storm begins to really surge?
It's a little tough. So the criteria for some of these drugs and management that Dr. Perez Morales was referring to actually suggests the patient needs to be inpatient and they need to be hypoxic, meaning they need to have an oxygen saturation less than 94%, and they need to have the presence of infiltrates, abnormalities on their chest x-ray. So those things, a lot of patients, like Dr. Perez Morales says, are at home and they're feeling not well, and they're actually suffering from something we term as silent hypoxia, meaning they actually have low oxygen saturation and they feel like crap when they walk to the bathroom, but they're okay if they're sitting on the couch watching Netflix, and their heart races a little bit, but if they settle down, they're okay. And their oxygen saturation is low. It's almost like if they're riding on a depressurized plane, and you're okay as long as you're sitting down in the cabin, but you don't feel good, because you realize that your oxygen's low. You wouldn't know that unless somebody's monitoring you, and you can get worse and worse. And we've seen it with some of the colleagues that we've even lost, and in patients that we've lost, where they stay at home way too late, and by the time they present, at that point they're needing 100% oxygen right on arrival. They need to be intubated within hours of getting to the hospital because they waited too long. What I loved about our program is that we were seeing patients in the ED and they didn't meet those criteria. They weren't desaturated, but you know what? They were maybe diabetic, or they maybe had other risk factors, or they were elderly. We said, let's give you this tool so that you can actually keep an eye on your oxygen, and we will keep an eye on your oxygen and avoid that period of silent hypoxia. So when they reach that criteria, we call them back in. and we bring them back into the hospital. And once they meet the criteria for treatment, then we'll go ahead and start, as Dr. Perez Morales said, we'll start you on some steroids, we'll start you on remdesivir, but more importantly, as he mentioned, those drugs are questionable in terms of mortality. I think what makes a big difference in mortality is not letting somebody die without support. So the issue is getting some oxygen on board. Yes, if you're like your patient's Bert, if they have coronary artery disease and they're sitting there with low oxygen status, that's not good, you know, and you're going to end up coming in with kidney failure and with a bunch of other problems because you're suffering from a silent low oxygen status and you have underlying disease process. So monitoring those patients and knowing ahead of time, hey, you know what? You're getting to a borderline state. Let's bring you in. Let's put you on some oxygen, or let's get you some home oxygen, or you know what? Or you meet criteria, as I mentioned, for some of these drugs, and support. So a lot of the best care here is not these drugs that everybody's touting. It's really the supportive care, making sure that you're eating, that you're well hydrated, that you're oxygenating well, and that all your organ systems are being taken care of. So it's the old critical care adage for us. You know, what do we do in the ICU? Well, what we do is we shore up your organ systems. You know, we'll support them. It's basically you are in the middle of an earthquake, which is this virus, and all we're doing really is holding on to your support beams. You know, we're going to go ahead and support your kidneys. We're going to support your lungs if we have to with the ventilator, but we're going to support them and make sure that all your organs are getting what they need. That earthquake's going to pass, like Dr. Perez Morales says. You know, eventually things will pass. The question is, what's left of the building? Well, unsupported at home, there's not going to be much left of that building. So being supported in the right environment is what we're looking for. And again, if you don't need to be in the hospital, perhaps, you know, this home pulse oximetry, which is becoming more and more available, is the way to go to monitor people and know when it is that they reach that criteria. But yes, I feel horrible about the drug situation. We've done over 500 convalescent plasma cases thus far in the Baptist Health System. We're doing it. I can't tell you, like Dr. Perez Morales says, that's like, oh my God, they received this and the next couple of days they're great. No, I can't tell you that's really happening. And I haven't really seen any drug where I've given the drug and in 2 days or 3 days, everybody is phenomenal. This has a clinical course. It's going to be different for each individual. Some people are more susceptible to this disease. We're learning more about the genetics and the pre-existing conditions as to how they play with this virus. But it's difficult. It's difficult, and there isn't a magic silver bullet here at all. And yet, 102-year-old can make it right through and smile through this disease. And unfortunately, you know, last week I lost a 30-year-old, you know, which didn't really have any pre-existing conditions. It's a really difficult disease process. You know, the best case is what Gabriel says, you know, take care of yourself. You know, take care of yourself, protect yourself, and do exactly what they're telling you. Don't get fooled. You know, wear some masks and keep your distance from people and be safe.
I was going to ask you, in the setting of there not being a lot of really high level, you know, usually in medicine, if there's a lot of treatments, it means there isn't one really good one. You know, Gabby Suarez, Dr. Suarez, should there even be a debate about masks at this point? And wouldn't the best way to not have a negative outcome from this virus to try to prevent getting it?
Yeah, so, you know, anytime we talk about treatment, we need to talk about prevention as well. And I think it goes beyond the basics of social distancing, wearing a mask, performing the normal standards of personal hygiene. I think that that's just common sense and common knowledge at this point. I don't think that there is a debate about that. I mean, we can get into the specifics of why a mask is important and debunk some myths if the audience wants to discuss that. But again, I think going beyond, you know, what's most important about prevention is taking care of yourself. You know, we have to realize that before COVID, we were dealing with some other epidemics. So obesity, 75% of the United States of America is either overweight or obese. 1 in 3 people are diabetic. Heart disease is still the leading cause of death. The majority of causes of death are preventable. Okay, so 75% of people in America don't get the necessary exercise that the CDC recommends. And so all these things make a difference. You know, Dr. Martinez can talk about forced vital capacity and how that's important and how exercise improves that. You know, if you're not exercising regularly, if you're not controlling your sugar, if you have pre-existing conditions like heart disease, I mean, you come in contact with this virus, the cards are stacked against you. And so there's a lot of things that we can do as individuals beyond just wearing a mask. I mean, that's common sense, that's obvious, and being socially distanced and responsible, and obviously
I can't tell you, Gavin, I can't tell you how many patients are coming into the office now, 3, 4, 5 months after quarantine started with a complaint of dyspnea on exertion, and it's new in onset. And, almost so many of them say, yeah, before COVID, I would go out and I would do my exercise. And, especially older patients who do daily exercise, whether it be 20 minutes or whatever, if they stay inside in fear of COVID and don't exercise, they're losing functional reserve and functional capacity that they had previously. And now things that they would do inside the house, like sweep or make the bed, is at the peak of their tolerance. Whereas before, if they were walking 20 minutes, they could do those things easier. That point, honestly.
As a primary care doctor, that's my biggest concern. And, we do take a very good social history, and I want to know what my patients are doing on a daily basis. And it's just incredible. I mean, people have been locked in their houses. The anxiety is high. They're eating a bunch of processed food and an exorbitant amount of calories. And that just needs to stop. And it's difficult. It's not easy. It takes the right, team to discuss that with the patient, to coach them, to maybe deal with some of the symptoms that they're having other than physical. I think we also had a very significant mental health epidemic here in America, and this has just exacerbated it. And so there's a lot that people are personally dealing with. But getting out and getting fresh air and walking around the block a couple times, doing that daily, I mean, that can make a huge difference. It definitely can. And that's really what I try to focus on as a PCP.
I want to talk about a little bit of good news, Bert, if you can let me.
Yeah, absolutely.
So one of the things that I'm really excited about right now is that our current surge didn't reach New York City proportions, right? So New York City death per 100,000 is 271. Miami-Dade County, we're sitting in the 70 range right now. So we didn't take off exponentially like New York City. So the question is, why didn't we take off like New York City? And the answer is, damn, this disease is controllable. You could see it. Behavior changes the epidemic curve. You're seeing it. And the best part is that we didn't have to fully shut down. Yeah, we put a curfew in Miami Beach and we can't go clubbing. Yeah, we can't get together, shouldn't get together, in large gatherings of greater than 10 people. But, we didn't put in really hard stuff here. I mean, people can go to work. We just need to change our work environment. I've been working the whole time because I can't stop. I think everybody on the panel here has had to go to work. And in my office, I could tell you, nobody's picked this thing up in my office. Why? Because, we're protecting ourselves from each other. We're all wearing masks. So we don't need to shut down our economy. We don't need to go broke. This is great news, and we've been able to flatten this curve back down, and we got our R0, which is a reproductive rate, down under 1 again. And we did that just being a little bit more weary of our surroundings, putting on our mask, not fighting about having to wear a mask outside, and, taking care of our elders, being less selfish, because that's really been the thing, about caring for other people. When you wear a mask, and we're all meant for others, it's really wear a mask for others, because when you're wearing a mask, you're out there protecting other people. And it's the most Christ-like thing to do at this moment, is to put that mask on, and do it for other people. Don't do it only for your dad and for your, and for your mom. Do it for your neighbor, and do it for your secretary, and do it for everybody else around you, because that mask works. It has worked. And that is great news, because I thought, oh my God, this surge that we were heading into, I thought, we're going to have to shut down again. You know what that means for the economy? That's horrible. And we didn't, and it's coming down. But I do fear that if we get lax about it come Thanksgiving, that things may change. And school opening is something that we're being very conscious about. I'm very excited about the way we're being careful about it. New York City's got a lot more people infected. They may have reached potential herd immunity. It's very possible based on the number of deaths. We calculate that 50% of the people in New York City have already been infected. We're going to watch them open the largest school district in the country, right? With 50% of the population being infected. And we're going to see what happens. And we're going to learn. Every day, Dr. Perez Morales and I and Gabriel, we're all learning by watching exactly what's happening. We have the studies, we have whatever, but the most we've learned is by watch this virus operate using people that have already gone through things. What we notice in the Southern Hemisphere now is that, yes, there was a hell of a spike during the winter season over there in the Southern Hemisphere. That's scary. So we have to be aware that we can't get lackadaisical about it, because here in Miami, we're only about at 13.5% of our population infected if you use a mortality rate and of 0.5 to 0.6%, and our current amount of deaths. So we are not anywhere near that herd immunity, so we need to be careful. But it works, and that's good news. I think it's really good news that we can get through the holiday season if we care for each other, wear masks, social distance. We can get through this, and hopefully a vaccine will come around that will help push that herd immunity number so that we can start getting rid of this virus.
Yeah, those numbers started going down about a week ago. It's not coincidental. That was 3 or 4 weeks after the July 4th holiday. Right before then, in May, things had kind of opened up. People were hanging out more. People were doing more things. It's not coincidental that 3 or 4 weeks after people started getting scared again and changed their behaviors again, that the numbers went down. And, the mortality numbers will lag a little bit here in the next couple of weeks, but we certainly have a positive pattern going. Dr. Perez Morales, I noticed you didn't mention one medicine, hydroxychloroquine.
Because it's not indicated, it doesn't work. There's several trials for treatment, prophylaxis, you name it, and it hasn't been proven to work. On the contrary, it's associated with a lot of cardiotoxicity, as I'm sure you're well aware of, and cardiac issues, including prolongation of the QT interval, torsade, arrhythmias, etc. And the studies don't show that it works.
Yeah, Jose, in your capacity, there's a role that the hospitals and health systems play in the education of the public. How are you guys thinking about education in your systems, of your employees, of your patients, and has that opportunity been something that's been exciting?
Well, so, we have a very robust marketing department corporate-wide that handles all of the different systems from Palm Beach down to Monroe County. And we've been very proactive through social media. We've engaged, in addition to just putting out videos about proper following CDC guidelines, proper hygiene, all of the things that folks are talking about. We not only promulgate that on our social media, but we expect that of our employees. As we walk in to any one of our facilities, we're temperature checked, we have to wear masks. Even visitation policies, we have to educate people regarding that. We've even incorporated into one of our social media campaign, we've contacted local influencers, whether they be sports players or musicians, showing them wearing their masks and following the proper protocols to make sure that the public is educated. So we've used all types of platforms, whether it be our newsletters, our social media, direct communication from our physicians to patients. It's very important for them to feel that, that we're a source of information that they can go to understand. And if I could just take one point, there's one question here that I'd like to ask that's on the chat, which is about morale amongst the staff. And I think the clinicians can talk mostly from the doctor's point of view, but looking at the hospital overall, I would tell you that people are tired. They're pulling many shifts. But the way that I see a lot of the nurses, the respiratory folks, is it's like this is the big game that they've been waiting for. So they're excited and energized to ply their craft against this disease, but they are tired. We've done some things to make sure that they get their rest. The state provided 100 nurses that were deployed locally. We've also brought down expert nurses to give our nurses breaks. In addition, the community has really responded incredibly. I can't tell you how many thousands of either meals or desserts or things have been provided by the community to our providers, and they have to follow very strict guidelines. They have to be single serving. They can't be served, from a buffet line. So I would tell you that the morale, people are tired, but I see them very excited to combat this thing through innovation, like Dr. DeBouchet said, and we really have depended on the community to support us. I mean, it's, the Blue Angels have flown over all of our hospitals to provide that kind of excitement. We've had the Miami Heat and some of our other sports partners show up with their famous players, making sure that, that the healthcare heroes that work here are recognized. I mean, the drive-bys at Baptist, I used to hear them at my house when they would beep and honk at 7 p.m. at the change of shift. So to answer that question, folks are tired. but they see that there's a light at the end of the tunnel, and it's not a train headed in our direction.
Yeah, that's the experience we found as well, you know, between my friends who are colleagues and physicians. It's been tiring. It's been a challenge. It's had to change the way we practice medicine in some respects, but at the same time, I think most of the physicians that I've interacted with are really excited to be doing this work and really excited to be a part of the solution. And that's why I guess maybe we're doing this today. Mr. Collins, old civics teacher, had a question. He said, when students return to school wearing masks, how can schools provide them and teachers periodic fresh air breaks so they aren't wearing masks 7 straight hours? I don't know if anyone wants to take that one, but I guess this might either this might be a part of the mental health question that Gabriel Suarez, either for the teachers or for the students.
Yeah, definitely, for sure. I can see the stress levels going up.
I got to take breaks when I'm seeing patients. I take the mask off in between. Take a break myself.
It's tough. It's difficult. Well, kudos to Belen because their reopening plan is amazing. I mean, I think they've done tireless work to put something together. It's actually one of the most beautiful reopening plans I've seen. That PDF looks great. But all joking aside, I think that they have a very solid plan in place. It's definitely going to be a very slow reopening in different phases, different hybrid situations. I think schools definitely need to get creative and be flexible, but I think the technology is there. Having kids, students in smaller, smaller cohorts, having kids in somewhat of a hybrid model would help in giving them some additional time away or out of the classroom. That's always going to help specifically to stop the spread or decrease the risk of transmission. So I think there are ways of doing it. And again, thankfully we have the technology. I think being in a classroom setting, and obviously we can all speak to this, is extremely important. I mean, some of the best lessons I learned were outside the classroom, you know, hanging out with my friends at Belen, and you know, it breaks my heart what's going on with sports now. You know, I'm a big proponent of kids being in physical activity. A big fan, obviously, of the Belen cross country team, and the fact that they may have to postpone or extend the start of sports is really tough. But again, it's going to take a lot of creative minds, which you know, in particular for our school, I don't think there's a lack of.
Yeah, someone asked the question.
You're still recommending those kids get a ton of exercise, I would imagine, right, from a family practice perspective.
Yeah, no, definitely. I mean, definitely. I mean, at least 60 minutes a day for sure, an hour. They need to be out there. They need to be running, of course, in a socially distant fashion. But it can be done. I mean, people need to be outdoors and need to be sweating and moving.
I think the job of the docs a lot of times has become a risk-benefit education for the patients. And so I think when we're talking to patients about any disease in the treatment, we're talking about the risk and the benefit of the treatment. I think we're going back to school, it's a little bit of the same thing. You know, families have to decide with their kids who in their household is high risk, what degree of risk they want to entertain for their household. Certainly sending your child to school is going to increase the risk of transmission of COVID. It could be done safely. All the schools and everyone is going to do the best they can. But I think individual families are going to have to decide based on the risk of the members of their household and the risk of their kids and their health, what it is that they want to do. I think, you know, the important thing for schools to do is to offer the appropriate guidance, to offer the appropriate opportunities to make sure that our kids are going to have access to education and access to the things that are going to help them grow.
Part of the decisions to bring kids back to school are being made both on the parochial side, on the, you know, and the county side, are being made based on the amount of active virus that there is on the street. So, and the reason, the way they determine that, and the magic number they've used, is that they're following test positivity rates. And they've determined that when test positivity rates get down below 5% of all tests being done are positive, that that suggests that the amount of virus on the street is low enough that the chance of transmission, like Bert was saying, is going to be a lot lower. So again, it's all risk benefit ratios. We're all Belen guys. We all had to suffer through all the math, through Vila's class and everything else. So you know, like the what you're thinking about is that it's, you know, it's math. You're going to do the math. You're going to have a lower risk, and when we have a lower risk in the community, then we're going to take a little bit more of a chance, because at the end, you know, the kids need to get a proper education. We need to raise our kids, but there are some individual decisions, like Bert says, about what goes on in your family and your household, you know, that will have to be taken into account. But we all love this plan that Belen's put together and the county's put together, that, you know, currently in Miami-Dade County, we are not New York City. You know, our viral replication right now is down below 1, thank God, but that means that the virus is slowly disappearing, but it hasn't disappeared. And it's going to take a few more replication cycles for it to get down to a point where the test positivity rate is under 5%. That's going to be a few weeks from now. So that's why they're going to take this month-to-month approach and make a decision based on what's going on in the community. And that's just making a smart move.
So we don't have too much more time. If you guys have any questions that you'd like to submit via the chat, you know, we'd be happy to share them with the group and see if we have any answers. There are other medicines that have come up over the course of the last 6 months that have come into question whether they should be used. I was wondering if anybody wanted to comment on non-steroidal anti-inflammatories like Advil, Aleve, and whether or not those medicines should or shouldn't be used. Kind of leave that open.
I've been telling our outpatients, the ones on our program with the remote patient monitoring, you know, if they're still having fevers, they've taken a few Tylenols in a row, you want to take a Motrin dose that day, you're feeling like, you know, like heck, you know, you take the Motrin dose. Right. At that point, I don't want them taking Motrin on a continuous basis because of other things, you know, in terms of their kidney health and their perfusion health and other components. But yeah, if it's to get down a fever, you know, and they've taken a couple Tylenol doses in a row and nothing's happened, take a Motrin dose and they feel better, we have been encouraging them to do that, you know, without much fear. No, Gabriel, how you've been?
Yeah, no, completely. I concur with that. You know, especially if it's just a fever, even just some body aches, definitely Tylenol first. I mean, I don't know that there's any strong evidence that NSAIDs should completely be avoided. But obviously, you know, a lot of my patients have other comorbidities, kidney disease, hypertension, and I, you know, usually avoid NSAIDs anyways. So, but it's, you know, safe enough to take a couple doses if needed.
Yeah, I mean, I couldn't agree more. You know, NSAIDs in general are not a good medicine. I tried to convince my mother-in-law for a long time. It has negative effects, increases the incidence of heart attacks and strokes, negative effects on the kidney, negative effects on the GI tract, and causing ulcerations. But it can be used in acute situations, and so it still can be used and certainly should be when appropriate. Other medicines that were in question previously were antihypertensives, and I think Gabriel Suarez touched on it earlier, that, you know, obviously the most important thing to do is to make sure your chronic illnesses don't become acutely worse. And so obviously medicines like your blood pressure medicines, you should definitely take. Just to kind of wrap it up, in terms of the vaccine, Russia already has one. Typically vaccines can take multiple years to put together and validate. Dr. Fauci, amongst others, are hopeful that we can get one either by flu season this upcoming winter or by the end of it. What is everyone's thoughts here on the vaccine, and what can we be hoping for going forward?
There's at least 120 vaccines that are being developed as we speak, perhaps maybe more now. There's at least 4 of them that are going on phase 3 clinical trials now. Moderna, Pfizer, Oxford, Biotech, now Johnson & Johnson. The hope is that these vaccines will be effective and obviously immunogenic. We don't have a lot of data on the preliminary information these companies have. And the first one to publish, you know, what they considered to be good data was actually flawed, which was Moderna. There was a lot of patients that had vaccines that they did not report on. So, you know, when that data finally becomes available, it needs to be scrutinized very carefully. because in order for the vaccines to be effective, you have to have at least 50% effectiveness rate. And, you know, even though we're all hopeful and optimistic that we're going to have a vaccine soon, unless it's a political maneuver for the coming elections in November, I just don't see how we're going to have a vaccine that is going to be widely available and distributed and manufactured from now until December. It's just impossible. I don't care what anybody says. I think it's just, from a practical perspective, it's impossible to do.
But do me a favor, and everyone, please take their flu vaccine, because coming into flu season, you know, at this time of the year, we normally end up sucking up about 40 ventilators, you know, during flu season, and we don't need that right now. We need every ventilator and every bed for COVID disease, you know, going into the holidays. One good piece of news is that other areas that have their flu during our summer, which is the Southern Hemisphere, had a better flu season, and I think, again, it has to do with better vaccination rate for flu and better social distancing and mask wearing. So please do your best not to get the flu. If there's a year to get a flu vaccine, it's this year. Please get your flu vaccine. It's extremely important to diminish the confusion between the two and to diminish the amount of flu this year.
As well as the pneumococcal vaccine for those who have it appropriately indicated, right, Dr. Suarez?
Definitely, 100%.
All right, Carlos.
All right, boys. Well, listen, we're going to wrap this up. I want to thank you all for doing this. Just so you know, this is recorded. We will be posting it on our alumni YouTube channel, also on our Be Connected platform as well. Any questions you have in addition to that, you can send them to belenalumni.org, and we'll hand them over to these guys, and we can post this in our alumni website, Belen Be Connected as well. Bert, Jose, Dr. Perez Morales, Eddie, Gabriel, thank you so much. I want to thank Jose Pep Lopez Varela behind the scenes. Like I call him my wingman. He's making sure everybody's behaved. And thank you, Batch, for sponsoring this and all the information. Okay, this is something that we're all in it together, and like I said, I'm very happy that we as an alumni association can put something like this together. So thank you, boys, and thank you everybody for coming on.